for treatment-naive intermediate risk non-muscle invasive bladder cancer, and the speaker will be Dr. Akash Shah. He's a uro-oncologist from Mumbai.
Hello, thank you for the Dr. Vivek and good team for giving me this opportunity. So my topic, as she rightly said, is a comparison between BCG and Intravesical Gemcitabine Docetaxel treatment in a BCG naive patient. So these are treatment naive patients who have not undergone any treatment previously. As we all know, so the intermediate risk is the primary goal here. There are a lot of studies on low-grade gemcitabine with docetaxel as a treatment profile, but here we are going to look into intermediate risk group, which we all know, and especially in that we are going to see high-grade TA tumors which are less than 3 centimeters to be considered for gemcitabine docetaxel. Of course, why the studies are being done? Because the availability of BCG is reducing over the time. The NCCN also prefers giving treatment options for other than BCG as mitomycin, gemcitabine, because of unavailability of BCG at multiple places, including India at present. AUA also positions in shortage of BCG to consider intravesical BCG option from either gemcitabine, epirubicin, docetaxel, either of these treatment to be considered as an alternative therapy in treatment-naive patients. Also, NCCN has suggested similar alternative options, including gemdosi, gemcitabine, epirubicin, valrubicin, docetaxel, and gemcitabine with mitomycin is also an option. Other than this, there's a feasible option to have a lower dosage of BCG, which could be considered, maybe 1/3 or a half dosage to be considered in these patients. A similar Jefferson SKCC oncology has also similar gemcitabine docetaxel or gemcitabine mitomycin to be considered in these patients. So this is a study similar to my study, where a retrospective data suggestive of 107 patients were considered only with docetaxel as a primary treatment, and it had shown a recurrence-free survival of 82% after 2 years, which is quite different from the primary study which I'm going to present. Of course, there are multiple other strains which have been tried, but that is not giving the outcome as considering an alternative option to BCG. Of course, there's a single agent which have been considered. All of them have shown that it does not show the similar outcome to BCG in all forms of treatment. So there's a multi-institutional retrospective data study with gemcitabine docetaxel, which had shown 276 patients from 7 institutes with survival outcome, with tolerance being lesser in 9 patients, with survival, recurrence-free survival at 60% at 1 year, 46% at 2 years, which is quite lower in patients compared to BCG itself. So yes, the primary study which I'm presenting is an EU retrospective study. It's in a treatment-naive patients from 2013 to 2023. The major problem with the study was gemcitabine with docetaxel were considered only in patients after 2019. Exclusion criteria with any tumor who are of course high-grade disease were excluded from this study. So the BCT protocol, so SWOG protocol is what we follow, but in this study there was a Judy's protocol which was followed, where intravesical induction therapy with 1 TICE BCG was given in 5 to 6 cycles as an induction, followed by maintenance therapy for a year only. So 3, 6 and 12 months. This is a specific indication where they have given only for a year, and only 3 maintenance doses have been given, with similar gemcitabine docetaxel where 2 years had shown a better progression-free survival. In this study, they are specifically given an induction followed by maintenance only for a 1 year with gemcitabine and docetaxel, which is given every monthly, and patients who did not take the treatment were given either follow-up cystoscopy was done stringently every 6 weekly. Right. So post-induction, how was the surveillance? Of course, cystoscopy becomes a primary investigation. Wherever there was recurrence, they did a re-TURBT. Suspicious area were biopsies, and post-operative, if the cytology was positive and there was no lesion, they underwent multiple random biopsy, which is standard protocol everywhere, I feel. The clinical pathological correlations were considered. Lesion, pre-treatment, year of treatment, and follow-up duration were considered. All the parameters were defined, that is high-grade recurrence-free survival, time to recurrence, other survival, that is including progression-free survival, were defined as per. Continuous variable analysis, that is median interquartile ranges and categorically variables like absolute numbers were considered using Fisher extract test. So let's come to the primary study. There were 483 patients, 127 from American Urological Association, 122 from European Association of Urology, and similar number of BCG and docetaxel were considered in these patients. The median, so the primary, it's a busy slide, but we need to go to the primary where pre-treatment tumor grade and low grade patients were the primary consideration, which you can see below, and the number of patients are similar in either of the groups in these cases. The adverse effect, which is seen in most commonly in BCG, were not true in this case. There was similar adverse effect in either of the cases, with grade 1 being the primary adverse effect in either of the arms. So survival outcome, that is the primary. So median follow-up for BCG was longer because it was there from 2013. This is docetaxel and gemcitabine was given since 2019. The recurrence rate was similar. The high grade recurrence rate were also similar. Disease-free progression, this is everything at 1 year, was similar. But you see the lower segment of the table where you see recurrence-free survival was better in BCG group at 1 year and also at the second year. Also any grade, if you see, including low grade and intermediate grade, the recurrence-free survival was better in BCG arm than the primary gemcitabine with docetaxel arm. So, of course, univariate and multivariate analysis were done in either of these cases, which show that low grade bladder tumors had shown lower recurrence rate even with gemcitabine and docetaxel, but in high grade primary tumor, multivariate analysis suggested that docetaxel with gemcitabine had high grade of recurrence compared to BCG itself. So BCG always showed an upper hand in all of these analyses. So this is the primary analysis. This is the AU analysis which showed high grade recurrence, and you can very well see that the BCG has shown lower recurrence rate compared to gemcitabine docetaxel group, also including the EAU group. So why is this analysis being done? So primarily to replace BCG, yes, because of the existing shortage, but still the recurrence rate in gemcitabine docetaxel arm is higher in high grade and also in intermediate grade of intermediate risk group to consider it into treatment naive patients, right? So, of course, there are multiple studies which are comparing these. Where are we at present in gemcitabine docetaxel arm is the phase 2 study which is running with 12-month efficacy with gemcitabine docetaxel being 88%. The grade 3 toxicity in BCG but needs to be assessed in head-to-head format, and a phase 3 AAU bridge study with BCG docetaxel is ongoing, which will let us know the further outcome. So, to conclude, patients with BCG is the primary treatment up till now until it is available. Of course, gemcitabine and docetaxel can be considered in a patient who is developing recurrence or who is not able to BCG unresponsive or BCG intolerant patients. Still, we need a further study to run. Also, the existing data is quite different. BCG has a long-term data, while with Gem-Doci we have a very short-term data to come to a conclusion. We need to study it further. Thank you.